Thank you, Dave. What I love about AME is it's an organization with passion. And nothing epitomizes that passion more than Dave. And so when Dave rings up, you know that you're going to promise more than you intended to do. And that was true. We got into an excited conversation about this topic that you were brainstorming. And I said to Dave, and maybe I shouldn't have done, I don't know, but I said to Dave, well, why don't I try and persuade Jim and John and Mike rather to come too? And, not just me come and do a third keynote for you, Dave, but actually, why don't we get the whole gang? And Dave said, could you do that? And I said, well, I'll have a go. And of course, John, being the Toyota skeptic, said, oh, I don't know whether they need another talk from me, and likewise Jim. But eventually I managed to persuade them through several more conversations with Dave. So that's how things happen. And it's over 30 years ago since Jim and I met and began our research on this whole lean thing. And goodness knows where it's gone since. We had no plan. We were just following our noses and following the interesting things that we were discovering as we began what we later called Gemba walks, but basically going and looking and getting out of the university world. So 30 years of work on lean, but manufacturing has been now doing this for over 20 years. And it's tremendous the way this is spread right across the manufacturing sector across the globe. But it is also sobering that, as we heard in Jim's talk, even some of the best organizations like Ingersoll are still only just at this point thinking of taking lean beyond the factory and beyond across departments and extending the whole value stream. We've been banging on about that for a long time. Thank goodness it's finally happening. It is a necessary breakthrough to leverage the capabilities we've been developing in managing the value stream in each department and in focusing that value stream through Hoshin activities. Actually, the horizontal piece is only now being elaborated, and I think it is the breakthrough, the necessary breakthrough. Now, interestingly, 10 years ago, the healthcare sector looked to manufacturing to get going because they faced a crisis which has become an enormous crisis everywhere, not just in the United States, a crisis both of budgets and of growing demand. And they looked to manufacturing and learned a lot of lessons from manufacturing. And boy, it has exploded in healthcare. There's no question. Every consultant and their brother, a lot of you manufacturing companies were very generous in helping that translation of concepts that was necessary from manufacturing into healthcare. And healthcare is now facing exactly the same breakthrough issue of how do we take this across systems and out of the individual departments in a hospital and run it right across not just the hospital, but the whole healthcare system. So I thought, well, maybe it's time to reflect on the lessons that manufacturing can learn about a common problem they share with healthcare. And to do that, we had a lot of discussion, and I ended up focusing on 3 healthcare systems that some of which I know, one of which I've worked in, one of which I live in, and one of which I discovered on my journey to constructing this talk. So I want to draw some common lessons out of those 3 systems that I think apply to all of us in trying to break through this frontier of making the horizontal flow value stream a reality. So the title of my talk is Lean Lessons from 3 Healthcare Systems. And that I want to draw a few lessons from each of those healthcare systems, and I have a surprise for you, which I won't reveal, but will become evident in a minute or two. So it's sometimes tough when you get an assignment in a place like Florence. First Lean Healthcare Summit I'd organized in 2007 brought the pioneers together globally for the first time, and somebody came up from the audience and said, well, actually, we're just starting this in Florence. Would you come and take a look? Well, you don't turn such an invitation down. I didn't know what I was going to see, until I got to Florence. And of course, if you've been to Florence, you'll recognize the dome. And I was taken only a few blocks, almost still on that photograph, to this hospital, Santa Maria Nuovo, a new Santa Maria hospital, which was actually the first hospital in the world, we think, to be established in 1288. And it's interesting that although the premier position for any family was to have one of their sons become the Pope, the second best in Florence at that time was to become the head of this hospital system. So this hospital system was endowed by a phenomenal amount of precious works of art that are now all in the Uffizi Gallery. Not all. Some of them are still in the offices of the executive of the hospital. Priceless, priceless Renaissance treasures in his office. So you get the impression that this is ancient. Now, Luigi was born in Florence, had a career in Fiat, and was a senior executive in their agricultural division, did lean across many of their tractor factories around the world, but called back to Florence to actually take charge of the healthcare system. And it's not just a hospital, it's all the primary care, it's prisons, it's safety, it's inspecting restaurants, it's all of the entire healthcare system for the Florence region. And he agreed to do that because there was a big question about whether they should turn this ruined, not quite ruined hospital into a museum, or whether they should maintain it as a hospital. And he said, I'll come if we both turn this hospital into a new lean hospital and use that to transform the whole of the healthcare system in Florence. And this is not a hospital in crisis, but it's a hospital that faces budget pressures and that is facing growing demands. And no sign of those budget pressures easing. So this is Luigi Maroni. Could have been, I think, a Borgia prince, absolutely. And you'll see in a minute. And you look at what Luigi did. He rebuilt the interior of that hospital, restored the exterior, and built a completely new hospital inside it on lean principles. And you'll see many of the things in his lean journey that are very common and you all know terribly well. Analyzing the patient journey, recognizing the common patient flows around which the hospital needs to be organized, actually doing an analysis of redesigning and engineering those flows, creating cells in the wards, and involving people, policy deployment process, and a training program. Now, all of those are very common in many healthcare stories, and you can go and hear the other stories from Virginia Mason and Theta Care and so on. But I just thought I'd give you a flavor of what I think is the kernel of what he's done. So the point isn't all of the things he's done, this is the core.
First of all, it seems simple, but has been very difficult. In each of the 6 hospitals, we have departments, small departments, surgery, cardiology, and so on. Each department has its own rooms, its own beds, 20 beds, its own nurses, 20 nurses, its own doctors, its own technicians, its own clerical people. And we have more than 100, 120 small departments, small departments around the company, because it's a large company. We cut that completely. Now we have only 9 large departments overlooking all the company, and we abolished these small wards, because a small department in an hospital in a small ward, there is a door, and in the other side of the door there is the boss, and he's the owner, was the owner. Now we cut completely that. In each hospital we have only 2 large areas, that is surgical and non-surgical, and so on. The nursery are not owned by each department, but are part of the system. And this is believe me, it was a nightmare. Because when I cut this department, here there is one guy that spent 35 years of his life to reach this post, to be a noticeable surgeon, to say this is my territory, here I'm the owner. That is part of the mentality of the hospitals. And to cut them and say, okay, good, you are a very good surgeon, but now we have to work in a process, believe me, it's not, it's not easy. It's not easy. Anyway, this is done. And now it's done 2 or 3 years ago. Now is in place that. This is the first important thing we did. Very, very strong, very tough. At that time, we arrived at a kind of little crisis with my people by saying we have to go ahead. I'll tell you something about that. This is the first one. The second, we work on process. This is the real case. It's one surgical patient in one of our hospitals in Florence, 2007. This is the trip that this guy has to do from home to home for a small surgical operation, nothing special. We used to force, and this is typical of the public sector really, also in various other administrations of the public sector, we force our patient, our people, our customer, to go through one organization that reflects the need of the organization itself, and not the need of the customer. And it's just typical really of the public sector, of the state sector, and so on. And also the big company, if you leave the organization alone, after 2 or 3 years, tries to organize them itself in such a way. Anyway, this is the part, we work on that. We redesign completely all the flows with the best practice that we are speaking about. All the principle of the lean has been applied with really everything has been done in the right way, let me say. And we design the hospital, dividing the hospital not by department, but by process and product line. I'll show you something. Applying the concept of the model line, when this is the part of the patient, everything has to support it. We will design our department in all the hospitals in such a way, we divide in 6, there are no departments I told you, we divide in 6 patient flow, in 6 big processes that are surgery and emergency surgery, eye care and low care medical, outpatient and obstetrics. We design completely and we move the organization around these flows. Any department now, intensive care, medical imaging, gives services, let me say, or gives support to that one. Again, it's easy to say, but it was really a long journey. We'll see something about the line. We also put line managers, each line, through each hospital, but also through the 6 hospitals, through the company, is managed by what we call line managers. We hire these young line managers that are engineers, like me, are not nurses, not doctors, but we hire engineers that particularly skilled in scheduling, in process flow, and so on, and they are the owner of the process. And again, this is something that was an innovation, but it works.
So the interesting thing there is that he did a deal with the docs where he said, in return for taking away your responsibility for the flow of patients, I'm going to give you additional opportunities to learn and deepen your medical skills. That's what I want you to do. But I'm going to take away the responsibility for managing the flow. I'm going to engineer those flows, and I'm going to manage them with engineers. So there was a very dramatic change and signal of a change, of necessary change in mindset from the people who had previously been the bosses of those individual departments. And he used the hospital, the reconfiguration of the original hospital, and they built another, and they reconverted a couple of others, 3 or 4 others. They used that as the opportunity to begin the change in mindset. A focus on customers, which was not there previously, and an understanding of the need to separate the medical knowledge from the process. Really quite fundamental. So that, to me, is the significance of that story, is that he used that event to actually begin the change in mindsets and the radical reorientation of the organization around process flow. Just like the early suppliers, I remember visiting Toyota suppliers, who all around 1970, 71 had fundamentally reorganized their activities from traditional batch to flow manufacturing, had done what I was later told by Iwata-san was kaikaku. So it's that shift, that dramatic shift, and you need some kind of event. You need some kind of way of signaling that things are going to be different. And that's the big lesson I take away from Luigi's story. He had the courage, he had the vision to lead that, and through his personality to convince everybody that that was a necessary step to take. But that's not the only lesson I learned in Florence. They then took me down some stairs into the basement and showed me this slab, as they call it. And they said, this is where Leonardo did his first dissections in secret to begin to understand the workings of the human body, to apply the scientific method to understanding how the human body works. And then they took me to the museum a couple of blocks away, where all of the wax models are still there that were created of the insides of the human being from the dissections. And by the way, it's just underneath Galileo's observatory. So it's just mind-boggling stuff in Florence. And standing there and recognizing that this is the birthplace of medical science, the application of science to medical issues, it struck me that this also has a lesson for us. Because actually I absolutely believe, that the scientific approach, scientific thinking, is at the core of Lean. And what we're trying to do is use, and I say this often to doctors, we're using the same scientific approach to diagnosing and treating organizational problems as you are using to solve medical problems. And the doctors say, well, yes, absolutely, it makes sense. Why wouldn't you do that? And you get them to reflect on, are they doing that in the organization of their work and in the organization of the hospital? And they say, well, no. Why don't we do a quality program instead? And okay, that's good, but in the end, we have to come back to the fact that actually, as we know, improving the process is the way of embedding better quality into the system. So, just some reflections prompted by that visit. Science, we think of science as being done in labs and written up in academic journals that very few except the experts read. That is actually not what science isn't totally about. If you read the history of, there's a brilliant book by Joseph Lefanu called The Rise and Fall of Modern Medicine, and he describes the 25 most important medical innovations over the post-war period. And they were all not developed in a lab. They were developed by people who had a way of framing a question and taking this burning question and going to very strange places, often by happenstance, and testing out and finding an answer. So science is really the quest for defining what we don't know and what we need to know. There's a tremendous book by Stuart Feinstein, too, called Ignorance. I urge you to read that book. It defines what science is really about, and that's the art of framing the right question. Very hard to do. We usually jump to the solution. So, lean thinking is all about practicing that PDCA method every day. How do you learn to play a musical instrument or a sport? You practice it daily. So the point of Kaizen is actually the practice of using PDCA in our work every day. And it's also about learning to take responsibility for solving a problem. To take responsibility for solving a problem with others using the scientific method. So it's about the capability of using the method and taking responsibility. And we develop that capability through asking questions of our subordinates, not by taking away the responsibility by telling them the answer. And you've heard a lot about that yesterday as well. Fundamental change in the whole way we develop capabilities. And if we are going to integrate a process with many, many steps and remove all the buffers that insulate the process from failures anywhere in the system, we cannot do that by separating thinking and doing. We can only do it by the thinkers and the doers who actually do the work, working together using the scientific method together. And this is where Lean parts company fundamentally with Taylorism. Taylor legitimized experts and consultants coming and doing it for me or to people. And we know that doesn't work. So that actually poses some very fundamental questions about our role. How do we learn to take responsibility and to develop the capability of others? Do we learn it by being Taylorist consultants going and telling everybody what to do? Or do we learn it by taking a line responsibility and learning to take that responsibility and develop others in a true line situation? Poses some fundamental questions about the role of us as lean experts and practitioners. So maybe we need to go and spend more time at the Gemba in a line management role, developing the credibility of learning to take responsibility and build capabilities, rather than become professional lean coaches. So think about that, quite profound. So, now for my surprise. In constructing this talk, I also came back to Canada, because I had a hunch that something was going on in Saskatchewan that was worth looking at. Not only was that hunch right, I think it's an extremely illuminating message. And I want to present to you Dan Florizone, who at the moment is the Deputy Minister for Education and the first Deputy Minister for Lean across government that I've ever heard of anywhere in the world. Prior to that, he was Deputy for Health. He was a healthcare CEO, ran his own hospital, was one of the first people to go down to Virginia Mason and get the inspiration, and then go and do it himself. And then was brought up to government level to do it right across the Saskatchewan system. And Dan is going to tell us more about his story. Dan, welcome.
Great, thanks, Dan. So whenever I'm introduced as the first deputy responsible for Lean, I hope I'm not the last. Or it doesn't come anytime soon. Thank you very much for the privilege of being here, and I come to you with the greatest of humility. First of all, I want to thank the Lean community, manufacturers, your teams, for sharing with both the health sector, now in my role as Deputy Minister of Education, the education sector, but also in my role for Lean deployment government-wide with the public sector. And I wanted to talk a few minutes about some of the work that's going on within Saskatchewan, but most importantly, the potential that this work has right across the country, right across North America, and I believe the globe. The background video that's playing right now is to a tack time of 11 minutes, 20 seconds. What's going on back there is a bit of the Hoshin Kanri work. You're going to see leaders, CEOs from health systems, from other systems as they work through. A lot of the video is healthcare specific. We have 3P application. We're building new facilities that are lean designed. And I got to tell you, it's some of the most exciting and inspirational work that we've been involved in. We've actually ignited a fire within the public civil service that we haven't seen in decades. And that is inspired by lean thinking, by a focus on the customer, by looking at the customer's experience, all of the touch points, all of the transitions, all of the handoffs, all of those issues and opportunities for improvement. It's fundamental that there be engagement. The individuals that are involved have been passionate. That's why they joined these fields, whether it's public civil service or the healthcare environment, or you become a teacher or a professor within the education sector. What we're really doing is we're not only giving them the time and the tools and the techniques to do this work, we're igniting a deeper passion, which is the why should we do it? And the why is fundamental to why we joined up into the healthcare system or the public service. So some of the work that was inspired, 2005, I had this great opportunity to spend a week in Virginia Mason. At that time, those were early days. They had shown great progress. Virginia Mason Medical Center in Seattle. I was able to go in on the floor, on a team, and participate in a rapid process improvement workshop. I can tell you as a former CEO and a CEO at that time that I had spent more time in the emergency department in Virginia Mason on that Gamba than I ever spent in the emergency department in the 20 previous years as a CEO. This opportunity and this learning to see, but most importantly, the lens that was placed on the improvement work where he measured value and waste from the patient's perspective was a deep and a profound learning for me. I had been involved for several decades in cost cutting, in dealing with budget constraints that required us to come in top down with decisions around layoffs and changes. And for the first time, I had witnessed a system, a method, more importantly, a culture that allowed us to view service, value, and waste from the patient's perspective. Now, the benefit of the Canadian system, Saskatchewan in particular, is that we integrate hospitals, public health, mental health, addictions, home care, EMS, all under one umbrella, one organization, one funding agency. And while we may contract with private providers for some of those services, we've got this great opportunity that has been largely unrealized to be able to bring the whole of the care continuum together. And what we saw in Lean was that opportunity to build value streams that extended well beyond the traditional hospital walls or within a manufacturing sector, within a particular process in the factory. We could go upstream, and we did. We went as far upstream as prevention and promotion, all the way downstream to be able to think about what happens after discharge, right through to recovery, rehabilitation, home care, home supports. Some of those approaches have allowed us to slay the wait lists within the province. And I'm proud to say that right now we're on track as a province in Saskatchewan to take our wait lists from what they were to 70 or 80% shorter. There's still work to be done, but it's some of the most significant improvements that we've seen across this country. I took the learning from Virginia Mason and I had a real dilemma coming home. How is it that I'm going to explain that I drank the Kool-Aid? Okay? And it's much like attending a conference and you hear and you're inspired and then you go back home and by Monday at noon, it's pretty much stripped out of you any positive energy that we can do something here. I spent the next few months deploying, and before I even said the word lean, there were a series of very important conversations that were held with medical staff, with administrative leaders, with the financial folks, with government, the funders ultimately. We deployed in 2006, and I can say that for all the fears and the worries and the consternation, there was a great appetite for change. In 2008, as a result of some of this work and also a role that I also played as chair of the Health Quality Council for the province, I was invited in to spread lean across the health sector. So I can say that since 2008, up until July, before my move into education, we have been active in deploying lean right across the health sector. The health sector in Saskatchewan has about 43,000 people. And I tell you that the magnitude of this deployment was something that was incredible, immense. We have Hoshin Cannery running throughout the sector. We have wall walks and huddles that happen on a daily basis in every facility, in every ward, right across the province. The lean training is learn, do, and we've got deployment across. I mentioned many of our facilities right now are being designed under 3P, with patients embedded on every improvement team and in every event that exists. I was invited then in 2010 to take what we had learned in health and deploy it across government. And I can say that the great work that's been going on right across the government of the province of Saskatchewan has really proven the concept that we've only touched the tip of the iceberg. Everything from time to trial, to application processes for horizontal drilling, to the time it takes to book a campsite, we've looked at through a lean lens. Now, Dan, what I want to say about the value stream and about the real gold in going government-wide across multi-ministries is that when we start to deal with some of the most complex situations, and I'll use an example on the human service side, those that have the biggest need, fundamentally, they may be bumping up against the education sector, or their children are. They may be seen in emergency departments. They may encounter social services or corrections or justice with issues. As soon as we start to bring the myriad of value streams together and make the individual and their family whole once again, we can then bring to bear the proper resource, the proper intervention, most importantly, the proper support to make and keep them healthy, to provide for that high quality of life. So there is an ulterior motive here, and that is that by working together, we not only achieve point improvement and across the horizontal line improvement, but we can move on to a much higher level of improvement by working together across ministries and ultimately on the ground, on the floor, at the level of the classroom, the ward, the community, to be able to affect change. 43,000 people in the health sector, 13,000 people in the education sector, 12,000 people working in executive government. We've got about 20,000 of them trained in daily Kaizen, daily the basics. We've got 880 healthcare leaders, probably about 800 to 900 across executive government that now have been more deeply trained. They become what we would hope to be, or hope to have, is the internal capacity to continue to drive the change. We're seeing results. I could tell you stories about fundamental improvements that are going on. And let me put it to you maybe in a way that isn't, well, it's so obvious. Government needs this. They may not have a profit motive, which they don't. So let's make it a motive around service. How about time? How about the bureaucracy to be able to streamline and simplify and put you as the customer at the center, as opposed to who? The system, the organization. We have purely been, in the past, not the fault of those that work in the system, it's a leadership failure. We have been provider-centered and system-centric for far too long. Now it's the day for customers to be truly brought to the foreground, whether those customers are individual businesses, whether they're individuals who seek service.
My involvement with the Saskatoon Health Region has been trying, rewarding, defeating, emotional, and rewarding. I continue my involvement because I have seen the benefit of it. I have watched light bulbs go on and hamsters run themselves off the wheel. The RPAWs have been the most emotional roller coaster out of everything, but also the most inspiring. I look forward to participating in more. My involvement as a whole has been invaluable to me. If I could leave you with something from me today, please let it be this. I believe. I believe in the work that we are doing, in the lean process, and I believe in everyone's ability to pioneer change. With remaining open-minded, working hard, and maintaining our focus and vision, we'll be able to provide our city and province with the health care it's asking for. It will not be easy, and it won't even be hard. It will be defeating and at times hopeless, but so rewarding and so worthwhile. So I want to thank you for your time today, but most of all, thank you for everything that you do and your team members day in and day out, because it is making a big difference.
That's the voice of our customer. Dan, thank you so much for this opportunity.
I just want... This is a seed that is going to grow. It's a pioneering experiment. I was blown out of my mind when I flew through here, saw Dave, and then went on another 3 hours to Regina, Saskatchewan, and walked with Dan to the Parliament building and saw the Hoshin for the whole of government in the Prime Minister's office, outside the Prime Minister's office, not focused on Hoshins for each department, focused around critical customer needs, focused on the needs of different customers for the system, and aligning the activities of the different ministries to synchronize that support, not just at the top level, but actually at the local level. I've never seen that before, and I think that's a critical frontier for lean. So what started in health, Dan is now taking into education, social services, corrections, economic development. It really is a great place to experiment. Only 1 million people, you can get your arms around it. It's a wonderful place to experiment. And I think this experiment is extremely important. So the Hoshin, I think, is a tremendous way of engaging everybody in a discussion about what do we want and involving the customers in that. And those 3P exercises, I walked around the 3P exercise, the results of the 3P exercise in the warehouse, quite fantastic. The contractors and the architects had to stand and listen. This was patients and the people actually running the service, the healthcare service themselves designing this. So really, really, really interesting. Talk about customer focus. This is about customer focus. And what's unique about this in government is you have doers who've done it as chief executives in their own operations leading this. That's totally new. And probably only could be done in Saskatchewan. But I hope could be done elsewhere now. Supported by politicians and by civil servants. Very important to back up the system behind these pioneering leaders. So I think this is a tremendous experiment and a lot of lessons here for how we translate lean across big multinationals. Exactly the same set of issues. But in this case, how we can affect local communities. So I think this is a new frontier for lean, and I'm extremely grateful that Dan's come.
Thank you.
To actually, in presence, give you a taste of this.
So I had 2 key messages I had to share on behalf of my premier.
Yes.
I'd like to invite you all to move to Saskatchewan.
In the summer.
Oh, don't say, we don't have winter. It's all good. It's all good. Ignore Dan. Number 2, when you see your kids, tell them to stay in school. Thank you.
Thank you, Dan. Now, I live in the UK and have watched the crisis evolve in the NHS. And I'm not being surprised about this. The NHS used to be thought of as the 3rd largest organization in the world after the Chinese Red Army and the Indian Railways. Statistically, it was the 3rd largest employer in the world. And we're now seeing the limits of that, of being able to run such a system from the center. And we could see this coming. So we thought the best thing we could do is not try and develop shiny hospital examples, and there are some very good ones, but we needed to dig deeper into the root causes, the real root causes of why this system does not work. And the more we've dug and done experiments, we've discovered not only is it about establishing basic operations management and the management system to go with it, it's much deeper than that. And you only discover that by conducting these experiments. So they've been very frustrating. Many of them have not worked But what they've done is revealed a deeper level problem that we've uncovered. So I just want to share a few lessons from those experiments. The first lesson is two sides of what I call value stream analysis, the ability to diagnose and see a whole system. And the first is actually understanding your demand. And in healthcare, there are a lot of questions about what is real demand and what is demand that's created by the way the system currently works. Unnecessary tests, unnecessary referrals, it goes on everywhere. Now, we may not, or we may be able to do something about that immediately, but we certainly have to think about that in designing future systems. How do we eliminate unnecessary, what Toyota call created demand, and really get down to what is really necessary to solve the problem? The second dimension of understanding demand is actually recognizing the common patient journeys. There are fundamentally two or three or four if you count obstetrics and pediatrics. There's the planned flow and the unplanned flow, the elective and the emergency flow. And within those flows, there's a core of very routine activities that account for most of the work, and there's a tail of complex activities that maybe need to visit 6 or even up to 20 specialists to diagnose a complicated problem. So we need to see those flows and organize around those flows. And we need to understand how predictable our demand is. These are data for a year for a very good hospital in the UK that demonstrate all of the demand is common cause variation. There's no special cause variation in this. And indeed, there's no winter either in this data. Okay? This is a year. And yet, where's the winter? We talk about the winter crisis and everything. And we blame incoming demand from customers. And yet, it's not there. Look at the data. So demand is actually extremely predictable. And we should easily be able to schedule to cope with that range of variation. But we can also do something about it. Because most of that demand, most of the chaos experienced in the system is actually self-generated by the system, not by customers. It's because of 5-day working in a 7-day world. It's because of scheduling vacations for doctors and key staff, which means that you haven't got quite the same coverage in winter as you have in the summer. It's about budgets, end-of-year budgets. It's about queues in beds in the emergency department, means you have to cancel elective patients and so on. This is a common phenomenon in every system. Most of the noise experienced by people trying to run the system at the front line is caused by the system itself, by us. We cause it, and we can do something about it. It's not the customer. This is true in retail, this is true everywhere, and yet we don't really like to see it. And I think this is management's responsibility to do something about it. If you as management are allowing this to happen, you are creating an unstable environment in which you're asking people at the front line to create stable and predictable processes. Impossible to do. This has to be addressed and surfaced. So that's one very important lesson. Go and have a look at your end customer demand and compare it to what you're asked to make and deliver. Second aspect, of course, is going and seeing the flow. And yes, frontline staff need to be allowed to map their own flow. And by the way, this is why you don't want to go in a hospital. That's what the flow looks like at the top left. Even more significant, a little bit later, is taking the executive team or the key leaders from different departments, particularly all the support functions, also on a walk to see how the system actually works, not how people think it works. So that's a mind-blowing exercise, and I'll show you a clip in just a moment. What we're doing is learning to see the system and learning to see why improving the emergency department is all very well, but will not be sustained if all you're doing is hurry up to wait because there isn't a bed. And recognizing that actually in the healthcare system, the problem is at the back end of the process. It's the demand to get out doesn't match the demand to get in. And yet to solve the demand to get out problem, yes, there's a lot of work that can be done in the hospital to improve the planning of that process, but it also involves collaboration with an external partner to plan the next step in the patient journey. So unless we start tackling that, all of the rest of the activities in the hospital will bear no fruit. So it's learning where to act to unlock the whole system that then will allow all of the other activities to begin to flow. That's a real skill and can only be learned by taking the executive team and walking the flow. And also then, recognizing that we need to build stability across that flow. So the core starting point is actually stabilize the data, the instructions, but also then stabilize the process. Because only on the basis of a stable process can you make scientific improvements that you can actually see whether they work or not. Here's another quote from a clip from an executive, the chief executive of a good hospital in the UK.
We dedicated 4 days to do the go-see exercise and seeing the patient's journey from door to door. Now you might say, well, 4 days is not a lot, but 4 days with probably upwards of 20 odd, maybe 30 clinical and non-clinical staff in a trust is quite a significant investment. The most important thing is when you hear colleagues who are very, very experienced say those magic words, I didn't know that this was happening here, and I want to put that right. That for me is the golden moment in doing this piece of work, and I think that's what then creates the stimulus and energy to see things delivered.
Again, the power of the walk unleashes an understanding of that we're in it together and we need to manage the process. So very, very powerful. That hospital is one of the best, lowest length of stays in the country. And yet, when we took all the support staff to map the process themselves, they could begin to see the importance of actually synchronizing all of the support activities to the TAC, to the patient journey. So, establishing a common operations framework, making the process visible so that you can see whether you're behind or ahead at the patient level, at the plan for every patient, in the ward level, at the visual hospital level, allows us to begin to trigger action. And to begin to manage for instance, the discharge activity on a regular 2-hour cadence so that we know that we are behind or ahead in managing discharge to free up the beds for the patient that are coming through the system. And doing that right throughout the hospital, that basic infrastructure. And this also requires hands-on. Somebody has to take responsibility for seeing the whole and managing the whole, both in triggering the actions that need to happen on a 2-hourly cadence, but also unblocking issues and escalating issues that need to be unblocked at a higher level. And also then for coaching and developing the right capabilities to address some of the problems in the current process as it's currently configured. So, who's responsible for your end-to-end value streams? A question Jim raised in his talk. Quite fundamental. So we can build the operations framework, we can create the stability. But also, the process itself needs a voice upwards to say what it needs, to scream, if you like, for support to unblock the ability to perform the work, the process the customer wants. So that's the foundation of a management system. Then at the top, a challenge for you is to go and look at your organization's list of projects. And I've seen in multinationals, typically at the top they'll have 50 or 60 projects, and then you go to the operations excellence department, they're doing another 50 or 60 projects. none of them actually related to core fundamental goals of the organization. Complete inability to plan. Well, healthcare has this in spades. I told you, healthcare is a management-free zone. At least it has been in the past. We put all the projects in a hospital on a wall. And we reviewed how many targets there were. And this hospital had 515 projects and reviewed 350 targets every month. And that was on top of the day job, which we did time analysis of senior managers. They were always 150% overloaded in terms of 100% availability of their time. So why would you expect any of these projects ever to be completed? But worse still, this is sucking management into meetings to justify why those projects haven't been successful. So management is totally drawn away from the shop floor, unable to support the shop floor because they've got important meetings to go to that are career limiting if you don't go to them. And that's the root cause of the NHS's problem, is you get another initiative from headquarters and another initiative from headquarters, and the management system has no capability of implementing them, let alone managing the day-to-day value stream that they're responsible for. We call this the Bermuda Triangle. And everybody in the NHS says, yeah, that's exactly right. So the actual root cause problem is the absence of a management system and the absence of an ability to prioritize. And fundamentally, Hoshin is about a series of dialogues around the key vital few actions that would make the biggest contribution to closing the performance gaps, and recognizing that focusing on time is a way of addressing the access issues, the quality issues, and the cost issues. So time is actually the core driver. And when the docs have done their quality programs, now it gets serious and we have to address time. So, how good are you at focusing on the vital few? How good is your organization? It is the hardest thing to do. Jim and I have tried to do policy deployment on ourselves for many years and failed every time. We can always dream up more interesting things to do than we have time. And then Dave Hogg rings up. And you add to the list. So that's life. But actually, organizations need to learn this skill. Not only mobilizing people to align, but also selecting the vital few. And finally, how do we then think about the deployment of the right projects to close the gap? Once we know the needs of the value stream, we can prioritize actions. Real skill of management is actually, and we can think of lots and lots of projects. I can think of dozens of projects that would follow on, and we've done quite a lot of these, explored a lot of these. But the key building block for management is actually the skill of learning how to deploy the right experiments to reveal the next set of underlying issues that management needs to tackle that are not immediately obvious. For instance, the whole financial reporting system in a traditionally public sector administration environment is completely incapable of relating process savings to cost. It's all about political negotiation of budgets. And the incentives all point in the wrong direction. So if we're going to build a management system, we also have to address the financial reporting system as well. That was not evident at all. And so on. The more layers of the onion, the more you get to the real root causes in such organizational issues. So we need a foundation, we need ability to focus, and we also need then the deployment in the right way of the right experiments to uncover the things we need to do next and address the issues. So, what can we learn from healthcare? Well, I think healthcare is one of the... I think the great thing about healthcare is that the patient is present and experiences the process. And so that you get a direct potential for feedback from patients. Second is it involves the deepest skills you could possibly imagine. Craft skills that are not standardized, but nevertheless deepest skills. And the deepest need to synchronize the horizontal. So the vertical and the horizontal, and the capability of problem solving and focusing. Those are our key needs. So, how is your organization going to prepare for these changes? So far, most of us have been improving existing organizations. And yet demands are coming, particularly in healthcare, but I think in many other industries. We have both the capability of talking and involving patients that we never had before through the web, and physically in public sector organizations, and retailing and so on. And we have to, I think, experiment with new forms of service delivery. The 3P exercises that Dan reported on are an extremely good way of beginning to envisage the future, the next stage in the future. And so I think the lean startup movement gives us some very interesting challenges of a different perspective in thinking about how do we design from a clean sheet the next generation product or process, the next generation service delivery. Because that's what we're going to need to cope with in the future, beyond utilizing the existing assets that we're dragging along behind us. So I think that's a big challenge for us all, is to think about what should we be doing to help our customers solve their problems in the future. And what is the right, that's actually the purpose. And what is the right process for delivering that? And what are the capabilities we then need to build to deliver that purpose? So I think that's the challenge, and that's the breakthrough that we need to make. And I'll leave you with some homework. I've mentioned some books, I've mentioned some video clips. If you want the references and if you want the links to those clicks, you can go to our website. This is the only advertising today. And it's not the same as Lean LEI's website, it's the Lean UK website. We also have websites in the UK. And if you go there, I've posted a list of all the links that I hope you'll follow up. And do read that book on ignorance. It really is, it will reshape the way you think about science. Because I think in management, science is central because it is about not just the practice of trying to discover laws. In such complex social situations, everything is always going to be situation specific. It's about learning how to diagnose that situation better each time. So it's about the practice of science itself, and it's about building stronger hypotheses for when you meet similar situations in the future. So it's actually central to our mission. It's not just about solving today's problem, it's about learning how to solve tomorrow's problem, and tomorrow's problem, and tomorrow's problem. So bear that in mind. We're all actually need to learn to be scientists in our daily work. That's very exciting. Thank you very much.